After 3 years, it shows progress of the ground glass opacity to reticular and honeycomb pattern. Now, there has been this discussion about semi-quantitative HRCT, where they have described a scoring scheme, scoring of all lobes for the presence of ground glass opacity on a scale of 0 to 5, and determining the total score for the entire lung was found to be a useful method to derive prognostic and diagnostic information about patients with idiopathic interstitial pneumonia. The sensitivity of HRCT for a confident diagnosis of IPF among a subset of cases with idiopathic interstitial pneumonia is low to the tune of 48%, but the specificity is relatively high to the tune of 95%. Now, ventilation perfusion scintiphotography is not really recommended as a routine investigation. However, two patterns of abnormalities occur: the non-segmental inhomogeneities due to localized loss of capillary bed and the increased perfusion of upper zones resulting from pulmonary hypertension, which induces an upward shift in the gradient of capillary perfusion. The ventilation scans reveal patchy non-segmental areas of decreased ventilation reflecting airways obstruction and alveolar destruction. These findings explain the hypoxemia and also to a certain extent suggest an anatomic reason for the VD to high VD to VT ratio in some of these patients at rest. The histopathology of usual interstitial pattern. Usual interstitial pneumonia is the histologic hallmark for the diagnosis of IPF. There is patchy and focal involvement of the lung with dense fibrosis, honeycombing, areas of normal lung adjacent to heavily involved areas. So this is classically the classic description of heterogeneity in the pathology slides. The distribution is mainly subpleural, paraseptal and peribronchiolar. Fibrosis shows temporal heterogeneity. Here we find the honeycombing in the subpleural region and lower lobes mainly. The central airways show are relatively normal. The microscopy also shows the peripheral inflammation and honeycombing. The UIP pattern shows heterogeneous changes with pale areas of loose granulation tissue, fibroblast proliferation, areas of dense collagen tissue, as well as the areas of normal lung. Also, the distribution of cyst formation and honeycombing is subpleural, as you can see in both these slides. The heterogeneous areas resembling acute interstitial pneumonia have also been described. A little higher power shows the peripheral honeycomb changes. Now, this is the classic UIP with typical heterogeneity, where in a single micro slide, in a single field, you can see areas of dense fibrosis, of fibroblastic foci, of normal lung, and the transition zone. This is classic. This is classic of UIP pattern which represents idiopathic pulmonary fibrosis. The surgical lung biopsy showing histological patterns of UIP, you can correlate it with the typical distribution as seen on an HRCT. Now, there have been quantitative patterns of histopathologic assessment. They have laid down criteria. There are 4 factors: the fibrosis factor, the cellularity factor, the desquamation factor, and granulation connective tissue factor. The scores range from 0 to 25, 10, 10, and 9. The maximum score allocated is about 54. Now, you can see that they have drawn relationships between the predicted DLCO and the desquamation factor, predicted DLCO and the total pathology score, the percentage predicted TLC and the cellularity factor score, and also the alveolar arterial gradient and the fibrosis factor score. And here we find the resting AA gradient correlating with the desquamation factor score. Now, what do we find? That the FVC percentage is the best predictor of disease progression. The advanced disease, as defined by a DLCO value of less than 39%, which are ideally candidates for lung transplant, and limited disease is defined as a DLCO of more than 40% predicted. So, the PFTs would aid in diagnosis, would aid in quantification and severity, and also it would aid in the measurement of disease progression. The various scores were studied, like cellularity score, alveolar space cellularity, fibrosis, and granulation connective tissue score. In survival analysis, it was found that only the granulation connective tissue score was the significant predictive factor in patients with IPF. Amongst all pathological scores, it was only the granulation connective tissue score which to a certain extent correlated with survival. Now, there has been these 2 scores, the clinical radiological pathological score and the composite physiological index score. The CRP score takes into account 7 criteria: dyspnea, chest radiograph, spirometry, lung volume, diffusion capacity, and resting AA gradient, and the exercise oxygen saturation. There has been a revised version of the CRP score in 2003. And the second score is composite physiological index score, which correlates with the extent of pulmonary fibrosis on CT, and it is a better mortality predictor than individual pulmonary function indices. Now, the ATS-ERS diagnostic criteria for IPF, you can see that even without a surgical biopsy, if you have 4 of the major criteria and 3 of the 4 minor criteria, you can diagnose IPF without a surgical biopsy. That is, the major criteria include exclusion of other known causes of ILD and abnormal pulmonary function studies, bibasilar reticular abnormalities, and a transbronchial biopsy. And the minor criteria includes age of 50 years, insidious onset of otherwise unexplained dyspnea on exertion, duration of illness longer than 3 months, and a bibasilar inspiratory crackles. Now, the natural history, the Kaplan-Meier plot of survival shows that the probability from the time of onset of symptoms compared to the time from initial visit. From time of onset, the median survival is about 80 months, and from the time of initial visit, the median survival is about 3 years. Now, the survival, of course, as is quite natural, decreases, the median survival decreases with age. Now, what about recommendations for treatment? The ATS-ERS has clearly pointed out that there should be at least 2 drugs which should be used, a combination of 2 drugs should be used, that is namely a corticosteroid along with either azathioprine and cyclophosphamide. Now, steroids have to be started with in a dose of 0.5 milligram per kg lean body weight per day for 4 weeks, then decreased to 0.25 milligram per kg body weight for 8 weeks, and then tapered to 0.125 milligram per kg body weight or 0.25 milligram every other day. In addition, one can use either azathioprine or cyclophosphamide. Both are to be used in a dose of 2 to 3 milligrams per kg with a maximum dose of 150 milligrams per day orally, beginning dose of 25 to 50 milligrams per day to be increased by 25 milligrams increments every 7 to 14 days. Now, in the absence of any adverse drug reactions, continue this combination for about 6 months. Perform a repeat evaluation at 6 months using symptoms, physiology, and radiology. And if the patient worsens, stop the therapy or change it. And how do you change it? You continue prednisolone and switch to alternate cytotoxic agent, or you consider lung transplantation. The various other measures that have been used are interferon gamma 1b, perfenidone, penicillamine, cyclosporine, and interferon beta 1a. Now, I would like to mention N-acetylcysteine, which has recently, after the trials reported in 2005-2006, that in a dose of 1800 milligrams per day, in addition to prednisolone and azathioprine, they not only reduced the myelotoxicity associated with the cytotoxic drugs, but also increased the physiological parameters that have been measured, like increase in the FVC by 9% and increase in the DLCO by as much as 24%. So routinely, they have superseded the ATS-ERS guidelines. Now, it includes a third drug, namely prednisolone, azathioprine plus azathioprine or cyclophosphamide plus N-acetylcysteine. It's a triple drug combination. Then, of course, we have lung transplantation. The various other measures include imatinib mesylate, transformation growth factor beta antagonists, endothelins, statins like simvastatin, and TNF-alpha antagonists like etanercept, warfarin, and of course, one must not forget to supplement with calcium and bisphosphonates when patients are being administered long-term steroids. The clinical improvement during midterm assessment includes improvement in symptoms, that is decreased level of dyspnea, specifically increase in the level of exertion, improvement in radiology as evidenced by reduction in the parenchymal abnormalities on chest X-ray and HRCT, and improvement in physiology as evidenced by a 10% increase in TLC or FVC with a minimum of 200 ml and a 15% increase in DLCO with a minimum of 3 ml per minute per millimeter mercury. Similarly, you have clinical stability and clinical deterioration. The guidelines have always been alluded to. Now, if the patient improves or is stable, continue the combined therapy using the same dose. Continue indefinitely only if the objective evidence of continued improvement or stability is there, not otherwise. The usual causes of death in a patient with IPF include Respiratory failure. The majority of patients die due to respiratory failure. The other causes include heart failure, bronchogenic carcinoma, ischemic heart disease, non-pulmonary infections, pulmonary embolism, strokes, and pulmonary infection and other causes. Now, there has been this entity of acute exacerbation of IPF. It is an acute, rapidly progressing disease with severe worsening of dyspnea or cough, and occasional systemic symptoms as fever, fatigue, and weight loss are present. Usually, the illness duration prior to presentation is about 4 to 8 weeks, and one must rule out other causes of acute worsening like infection, pneumothorax, pulmonary embolism, and heart failure before arriving at the diagnosis of an acute exacerbation of IPF. New or progressive diffuse pulmonary opacities are found on chest radiography. Lung function would usually worsen, a decrease in the PaO2 of more than 10 mm mercury from baseline. The histology would reveal late or organizing stage of diffuse alveolar damage, in addition to the features of their chronic UIP pattern, and there is a prominence of active fibroblastic foci on lung biopsy. Many of these patients would require ICU admission. The decision to mechanically ventilate should be carefully done after weighing the long-term prognosis. Mortality during hospitalization in these patients is very high, about 65%, and those who survive have a poor prognosis of more than 90% mortality at 6 months following discharge from hospital. The other problems of management of IPF include pulmonary physical rehabilitation, cardiovascular disease, pneumothorax, pulmonary embolism, pulmonary infections, lung cancer, and gastroesophageal reflux. What are the predictors of high risk in patients with IPF? They are male gender, mucus hypersecretion, moderate to severe dyspnea with exertion, smoking history, moderate to severe loss of lung function at presentation, and neutrophilia or eosinophilia on bowel fluid analysis. A decrease in the surfactant protein A content and the surfactant protein to phospholipid ratio would also ensue a poorer prognosis. Mixed ground glass and reticular opacities, predominance of reticular or honeycomb changes on HRCT, and increasing age are other risks of other high-risk predictors. The favorable indicators of survival include a younger age of less than 50 years, shorter symptomatic period before initiating therapy of less than 1 year, being in an earlier stage of disease, that is less dyspnea, more normal lung function, less parenchymal disease or chest radiograph or HRCT, showing beneficial initial response to the steroid therapy, and female gender. Before I conclude, I would like to emphasize that IPF is a disease that entails a very high morbidity and mortality, and earlier we diagnose the disease, the higher are the chances of a favorable prognosis, and these are the patients who need to be treated aggressively on the guidelines that have been mentioned. Thank you very much.
Well, Dr. M.K. Sen, I would like to ask you, what is the role of lung transplantation in IPF?
Lung transplantation, as I have just mentioned, is it's a very important modality of treatment for patients who have fairly advanced disease. I've categorized those. They have categorized the disease into the limited variety and the aggressive variety. The advanced disease, as characterized by an FVC of less than 60%, with DLCO of less than 39%. These are the patients who have already been tried. The drugs have already been tried and they have failed. And patients who have been explained the prognosis, the family of the patient and the patients themselves would know the prognosis of the disease. The modality of choice is single lung transplantation. Unfortunately, we don't have an organized lung transplantation program in our country, but it exists abroad, and the chances of survival are pretty encouraging. The 5-year survival is to the tune of 50% in some centers abroad.
Okay. And can you please tell us about emerging drugs in the therapy of idiopathic pulmonary fibrosis?
Yeah, there have been many developments as far as the pharmacotherapy is concerned. Since the response to pharmacotherapy is not very encouraging, they have tried many modalities, which includes initially the pathway that was selected was anti-inflammatory drugs. Mm-hmm. However, it was found that inflammation is not the only mechanism of pathogenesis. Later on, the various pathways, the cytokines have been tried, the mediators like epidermal growth factor receptors, the proteinases, and oxidant pathways, they have been tried. And of course, finally, there are drugs which affect the fibrogenetic pathway. So the cytokine, which is basically the transformation growth factor beta 1, that is the major cytokine which is involved in fibrogenesis. So there have been various agents which have like interferon gamma. Interferon gamma has been tried primarily because it antagonizes transformation growth factor 1, beta 1, and it actually retards fibrogenesis. So these are some of the pathways that have been tried, and many drugs have been tried, like parfenidone, they have tried bosentan, they have tried warfarin. I've included many of the drugs in my presentation. Some of them do have very encouraging results, but the sheet anchor of pharmacotherapy now, as on date, remains a triple drug combination wherein one uses an anti-inflammatory drug. The best drug would be a corticosteroid, a cytotoxic drug like azathioprine or cyclophosphamide, and a third agent is an antioxidant drug. You know, the oxidant injury is prevented by reduced glutathione, which is the production of which is encouraged by the use of N-acetyl-16. So 1800 milligrams per day is the dose. So the combination of these three drugs are routinely tried for initial therapy of IPF.
Okay, and what is the importance of lung biopsy in the diagnosis of IPF?
Lung biopsy, as I have mentioned, you know, according to the guidelines of the American Thoracic Society, European Respiratory Society, lung biopsy remains an integral part because it is basically a clinico-radiological pathological diagnosis.
Okay.
So if you have seen the major and the minor criteria, even where you don't go in for a surgical lung biopsy, one should at least include a transbronchial lung biopsy. Now, the surgical lung biopsy today implies the video assisted thoracoscopic lung biopsy. The procedure is relatively non-invasive and is associated with less morbidity.
Okay.
Now, lung biopsy remains essentially a very important criterion in the diagnosis of IPF.
Can you please tell us something more about HRCT, high resolution CT?
High resolution CT is a modality of choice. In fact, it is indispensable in the diagnostic armamentarium of any ILD in general and IPF in particular, because I have told you that the changes of ILD of IPF include the reticular pattern, and in advanced stages it is honeycombing, and these changes are basically peripherally distributed. They are subpleural and they are basically in the lower and middle zones. They are basal. Okay. So any involvement which is in contradistinction to these guidelines, that is those which are centrally situated or those which are involving the upper lobes of the lung, one should definitely go in for a biopsy. One should go in for ruling out other conditions. So if we have the peripheral and subpleural distribution of opacities, and particularly if you have honeycombing which shows, and traction bronchiectasis which shows a fairly advanced disease, one is relatively sure that one is dealing with this sort of disorder.
Okay, thank you so much, Dr. M.K. Sen. And friends, that was our first session of today's teleconferencing program. The topic was idiopathic pulmonary fibrosis, and Dr. M.K. Sen was with us, who is a senior chest physician in Safdarjung Hospital, New Delhi. And in our next session, after 15 minutes, we will be back with one more topic. The topic would be interstitial lung disease in collagen vascular disease, and Dr. Deepak Bhattacharya would be with us from Safdarjung Hospital only. And for that particular session, you will have to wait for 15 minutes. We will be back. Till then, keep watching Gyan Darshan.